My brief was to talk about quality beyond tertiary care and talk about WHO's program for improving hospital care. And I think the end part of the talk was how the World Federation could perhaps contribute to this. I think it vied for the longest title of the talk that probably Alan won. But I wanted to pick up some of the things that Alan spoke about in his talk. So this is the talk. We know that from the last sort of decade that there's much evidence being collected that quality of hospital care for seriously ill children in less developed countries is actually quite poor. There's marked scope for improvement, as Kath mentioned before, and others have mentioned during the week. A study done in 21 hospitals in 7 countries in the last a few years ago showed that almost 3/4 of children had received substandard care, even if your framework is relatively basic. So lack of triage, inadequate assessment, late treatment, inadequate drug and oxygen supplies. Health workers had poor knowledge of treatment guidelines, and there was insufficient monitoring at a hospital level. And it seemed like the greatest potential for improvement was at a rural district hospital level, but also at a regional hospital level. So major scope for improving quality of paediatric care. Since that study, there have then been other studies in other countries, and similar results have been shown. So in Kenya, there's a series of studies done by Mike English. In Central Asia, Giorgio and others were involved in studies in several ex-Soviet republics in the Solomon Islands, Cambodia, Angola, with some national differences in terms of the nature of the problems. All countries had major scope for improving the quality of paediatric care. So I wanted to show this morning that even though you may live on the dark side of critical care, you can still, the dark side of this critical care public health interface, you can still be involved in these issues. And I think recently it was said that clinical care for seriously ill children in district hospitals is a global public health issue. And in fact that we've heard a bit about the inequities in access to care, but I would suggest that inequities in quality may be as important in terms of the achievement of the Millennium Development Goals as inequities in access. This article made the point that if hospitals are perceived as expensive places to die, where there's little prospect of effective treatment and where services are poor, why in fact would parents follow referral advice? So if you think about the sort of regional and district hospitals, unless you make them of adequate quality, then parents aren't going to. They're going to vote with their feet, as I think Zulfi said. They're just not going to come. So I might actually skip through this, but I showed this a little while ago. If you think about the sort of many factors involved in quality of care, we always think about the sort of buildings and infrastructure of a hospital. We think about drugs and their availability, but there's many other factors too. Supportive technology and making sure that's adequate. Human resources has been focused on quite a lot this week. The presence of clinical guidelines in all of the studies in all of the countries that have looked at quality of care. The absence of up-to-date evidence-based clinical guidelines has been a feature and has been a limiting factor to health workers who are relatively not expertly trained being able to deliver good care. Giorgio talked at length about health financing, and in many countries having barriers to access that are not geographical but are financial is a major impediment to children receiving good quality care. He also spoke about the interface between hospitals and the community, and this issue of demand and care seeking. I've seen in many countries poor quality hospitals are empty because the community does not come because there's no demand. When you improve the quality, then people will again vote with their feet and come. Some countries have incorporated quality improvement strategies, overall quality improvement strategies into trying to improve hospital care. When Alan spoke this morning about how paediatric intensive care had gone somewhat from sort of technology-based interventions making a big difference to quality and safety interventions making a big difference, and there's no particular reason why those sorts of principles shouldn't be applied also to hospitals in developing countries. And as we spoke about before, earlier this week, the issue of having child-friendly facilities is important in terms of community demand for facilities and in terms of the quality that they provide. So WHO has a program for improving the quality of paediatric care, and it involves these areas, some of which you've heard something about. One is to have evidence-based clinical guidelines. It's not enough to just produce technical resources and expect people to use them. You can write as many books as you like, but if there's no strategy for implementation, then it's unlikely to have a major impact. So there are training resources that are now available. There are programs on appropriate technology. Particularly, I'll talk a little bit about oxygen and how that can be a crucial factor in improving the quality of hospital care. Howard's talked about essential medicines, but I think all of these things are part of an overall package of improving the quality of hospital care. The clinical guidelines provide national standards in terms of clinical policy. There are also assessment tools for evaluating the quality of care, tools for audits, which we in the critical care community are very familiar with, and there's evidence to support all of that. This is the main thing I wanted to talk about, and that is something that Alan raised this morning. In almost all countries where it's been looked at, there's no evidence-based clinical guidelines. And this book, the Pocket Book of Hospital Care for Children, was published in 2005, so it's a relatively new book. There's about 50 copies over on the desk, so if anyone's interested, please feel free to take 1 or 2 copies. I think we'd probably have enough for at least one for everyone who's interested, and maybe 2. The book is not just in English. I have here the Chinese version, the French version, the Turkish version, the Russian version, and there's also a Portuguese version as well. So this is a book that contains evidence-based practice guidelines for the management of all common acute conditions in children. It is integrated with the Essential Drugs Program, so it requires a minimal amount of essential drugs and basic equipment and laboratory facilities. The book emphasises the processes of care, not just giving drug treatment. I think in most hospitals the concept of hospital care is just make a diagnosis and give some drug treatment. And in all the surveys of quality of care that have been looked at, some of the issues of triage and assessment and monitoring have been major deficiencies. Provision of supportive care like intravenous fluids, blood safety, and antibiotic safety and nutrition are key features of good quality hospital care. As I said, the book comes in several languages now, the French version and the Portuguese version. There's Russian and other versions. The book is divided up into several chapters and covers the major common conditions affecting children, so cough and difficult breathing, diarrheal disease. I won't go through this because I think you can have a look at it yourself if you want. It focuses, as I said, on the processes of management, not just making a diagnosis and giving drugs, but it focuses on all the areas that were found to be deficient in hospitals throughout the world. So triage and emergency treatment, taking a history and doing an examination. Surprising how deficient that can be. Laboratory investigations, making diagnoses, remembering that most children who present to hospitals who are most likely to die have more than one diagnosis. They might come with one problem, but they have more than one diagnosis. Focuses a lot on monitoring and supportive care, planning discharge and following up children who have been critically ill. There's a CD-ROM to train health workers on how to use this book. As I said, it's not enough just to send a book, make a book available. You need to teach people how to use it. Alan spoke this morning about how training had been so crucial to improving the quality of paediatric intensive care, and the same applies to hospitals throughout the world. That CD is also available in Russian and Chinese. WHO has other resources that interface, I guess, with at a district hospital level. There's a book called Surgical Care at a District Hospital, which is, I think, an excellent publication. It provides standards for surgical care in various levels of hospitals, and also outlines what appropriate intensive care services should be in district and regional level hospitals. As I said, there are to understand initially where the problems were in paediatric care, there was an assessment tool designed for evaluating the quality of hospital care. This is a tool that's been used in many countries now by clinicians in collaboration with often Ministry of Health officials and external experts, and that can define what the national priorities are in paediatric care and develop an action plan. I won't go into these because we're running short of time. I was going to speak a little bit about appropriate technology because I think it's a clear interface between critical care and global child health throughout the world. And this is just one study that looked at, this is a compilation of all the studies that have been published on the prevalence of hypoxemia in hospitals among children who present with pneumonia. And it turns out there's about out of 9 high-quality studies, there are 5,000 children, of which 21% were hypoxic. So probably throughout the world, 21% or about 1/5 of all children who present to hospitals have hypoxia. So we estimate, based on the number of children who present to hospitals throughout the world each year with pneumonia, that there are 5 million children presenting to hospitals worldwide. Well, how often is oxygen available? Well, there's not much data on this, but we know that it's not available to all children. So some work in Papua New Guinea looking at 1,300 consecutively admitted seriously ill children in 5 hospitals. 22% of those couldn't access oxygen at the time of admission. Similarly, in Kenya, some work by Mike English showed that only 60% of children who were prescribed oxygen by a doctor in an emergency department actually received it. And similarly, in South Africa, 39% of rural health clinics and 18% of district hospitals had no oxygen. So things we take for granted in Boston, Toronto, Melbourne and other places are clearly not available to most of the world's children. There's a program now, which I won't go into details because we're running short of time, but a program now to try to improve the quality of oxygen that's provided in hospitals, and it's being implemented in several countries, in Papua New Guinea, in Malawi, in Mongolia, and previously in Egypt. And it's based on simple technology that I think is implementable in almost all district hospitals. I emphasised the other day it's not just it's important not to just think of hardware but to also think of systems, and so it's no point just providing equipment without actually having a system. And this program on improving oxygen systems, I hope, if it's scaled up, will make a big difference to pneumonia mortality. I'll skip over this, I think, and this. We know that quality saves lives, even in resource-poor areas. And there's pretty good evidence now that improving the quality of case management in hospitals saves lives from severe malnutrition, from severe pneumonia. You can get impressive reductions in case fatality rates from pneumonia by just providing reasonable and reliable oxygen systems. And we know that improving quality saves lives in neonatal care as well. In countries that have implemented the recommendations in that book as guidelines for neonatal care, hospital mortality has markedly fallen from low birth weight and from sepsis particularly. What's the evidence that all this works? Well, WHO and several organisations now have put together a website. This is www.ICHRC, the International Child Health Review Collaboration. And this website is a repository of all the evidence for the recommendations that WHO has developed on hospital care for children. I won't. I was going to click on the website and show you, but we've run a bit short of time. So if you're interested, go to this website. This contains, as I said, short reviews, not extensive Cochrane reviews, but short reviews of evidence behind WHO's recommendations for paediatric care. Why document the evidence? Well, it's important if people are going to be providing recommendations to have some sort of systematic resource for updating that will also assist in implementation. Many countries say, well, we don't do this, we do something else, and there's a lot of very unusual practices being out there, and providing evidence assists with implementation. We also hope this website will broaden the network of people who have some ownership over WHO guidelines. I think too much in the past, guidelines such as what I'm suggesting have been written by experts, and there's been no engagement with people who are working in the field, and this is an attempt to address that. We also hope that this website and this process will actually make evidence-based practice accessible to people, and there are several universities that are involved in this project where it's an entry point for learning about evidence-based medicine. So far there's been 150 reviews commissioned and more than 200 paediatricians and students involved throughout the world. There's 40 reviews published on the website. I won't go through the rest of it. It gets about 8,000 hits per month, so it's getting accessed quite a lot. So what have countries done in terms of improving quality beyond tertiary care? Well, many countries are involved in this process. There are probably several others. But this is what mostly they've done. Most countries have sought to understand the problems that they have in their own country. So done some assessments of quality of care, either extensive throughout the country or just in a few hospitals, to try to get some understanding of the local problems. There's then been a policy decision to implement the WHO hospital guidelines, that blue book, and other reforms that have come from these inquiries, and then adapted the guidelines to match their own local disease patterns. Obviously, the Russian version of this book is not the same in content as what the version of the book that's appropriate for Ghana is. They've adapted both the recommendations, the guidelines, and also training packages. They've run implementation workshops. And there's been early attempts at incorporating these guidelines into medical schools and to nursing curricula. I think clearly if this is going to go to scale, then it needs to be part of the health, and it's going to be part of the health culture. It has to be incorporated into colleges of learning. The countries have also been addressing other issues of health policies. In some countries, focal areas or unusual areas of practice, such as antibiotics for diarrheal disease and prolonged hospital stay that were found in sort of Central Asian republics, the overdiagnosis of neurological disease, have been addressed with health policy reforms. And some countries, as I said, are trying to address other important sort of hardware issues, such as improving oxygen systems. So I want to now just touch on whether or not there is a role for the intensive care community in all of this. What's the relevance of all of this to us? And I think that people who have been involved in intensive care have some understanding, have a good understanding of quality in acute care, probably more so, I think, than most people who are working in an organ-specific subspecialty. They have an understanding of appropriate technology and systems and evidence. Why would we want to do it? Well, it seemed to be that part of the motto of the World Federation. If we're going to live up to that motto, then perhaps we should do something about it. But there's value in improving the quality of referral and pre-referral management, and there's value in improving the capacity of smaller hospitals to manage children without referral. And as was said at the start of the week, there's value in doing this to improve equity and access to quality acute health care, which is a mandate of the World Federation. So where to start? Well, there's potential for partnerships with other hospitals in your country if you come from a transitional or resource-poor country. There's potential for partnerships with neighbouring countries, either assisting with training or support for quality. There's a need for more research to identify local system problems and more effective strategies for implementation. There's clearly a research agenda, a health systems research agenda here. I wondered whether or not it might be valuable for the World Federation to publish endorsed standards of acute hospital care based on WHO standards and based on the sepsis initiative that was presented earlier this week that's appropriate to tertiary level hospitals. I mean, for the World Federation to endorse these standards may actually be of great assistance in implementation in countries that are looking to a global body for endorsement of their approaches. And I think the World Federation, as I said at the start of this week, has a key role in advocacy for improving the quality of hospital care, for improving investment in child health, improving the investment in human resources and other key areas. The World Federation's not uniquely placed, but is well placed to be doing those things if we choose to. I wanted to finish with this slide, and I think we perhaps should have I was speaking to Joe Carcillo this morning about the changes that have occurred in hospitals in the last 20 years. In 20 or 30 years ago, hospitals were considered by many to be core social institutions. They were considered that because hospitals provided free access to services. And then the World Bank and the International Monetary Fund imposed some restrictions on many countries to request that they have programs of cost recovery where hospital care needs to be paid for. And I think that we need to rethink what hospitals are. We need to rethink that they are not just mechanical structures to deliver technical interventions the way the post office delivers a letter. I quite like this article But we really need to think of hospitals as being core social institutions. And in fact, the way people are treated in hospitals actually has the potential to worsen or to mitigate the effects of poverty and social disadvantage on health and development. This was a paper that's written by Lynn Friedman, who's an obstetrician, talking about how to achieve Millennium Development Goal 5, but I think it clearly relates to Millennium Development Goal 3 too. So we need to have a new vision for what hospitals are, how they can contribute to the community. So thank you for your attention. I'm sorry I've gone over time.